So, in the last class, we had discussed regarding aneurysms as to the diagnosis, SAH, and the various aspects, and which how each and every modality is useful in the diagnosis and further treatment planning of aneurysms. This time now we'll be going towards the endovascular options of treatment. Of course, see, there are surgical options, but that will not be maybe specifically asked to you. That is involves primarily clipping, where they surgically go in and put a clip across the neck of the aneurysm. So that is finally done by the surgeons. So what we will be focusing on are the treatment options that are there for endovascular procedures that can be done by an intervention radiologist. So the basic problem with the treatment is that why are we treating the aneurysm? Either it is unruptured and we want to prevent it from rupturing in the future, or it has already ruptured and now we are avoiding a re-rupture, because the problem is that once an aneurysm ruptures, the chance of re-rupture is extremely high in the next 2 to 4 weeks. So almost there is a 50% chance of re-rupture, and the mortality with repeat SCH is extremely high. So in ruptured cases, there is no deciding, there is no doubt that we have to treat. Patient is affording, not affording, they are willing for treatment, what is the GCS, all those things are a separate issue. But if money was not a concern, any patient who has intact GCS, in the sense it's not like towards brain dead, but there is recoverable GCS, you have to treat the aneurysm because you want to avoid the re-rupture, and you can't predict will it take 2 days, 1 day, 4 day, 5 day. So as early as possible, you have to do the treatment. When it comes to unruptured aneurysms, then there is a problem because we are not really sure about the natural history of the disease. See, somebody had an headache, incidentally detected to have an aneurysm. Now, whether to treat that patient or not is a separate dilemma. There, you have to tell the patient that if it is less than 4 mm or is it less than 7 mm, then maybe you can follow it up. The problem is the data there from where this 7 mm cutoff used to come was a Finnish study, and the size of the patients there is significantly bigger. So their cutoffs were different. In our country, we usually use 4 mm minimum. If less than 4 mm, you can give patient both options that the rupture risk is also kind of low, and also the morphology. If it's an irregular aneurysm, then there is a higher chance. Then we started doing vessel wall imaging. So if there is an inflamed wall, then there are higher chances that it may rupture. So in the unruptured ones, keep a ballpark figure of less than 5 mm. You can give the option, tell them that it might rupture, but there are risks associated with the treatment as well. More than 5 mm and intradural location, the chances of SAH and the comorbidities, the problems that will occur if SAH happens, the mortality with even the first episode of SAH is significantly high. So there the balance goes in favor of endovascular treatment. But of course, sometimes some patients may still go for a conservative management because you can only give the options to the patient. In cases of unruptured ones, we don't keep the patient admitted with us if he is not willing for treatment, because it just doesn't make sense. Because if the patient, something happens to the patient in the hospital while they were there and they are not willing for treatment for the ruptured aneurysm, then it becomes a big problem for us, because a re-rupture can lead to death and we have to take proper consent from the patient that they are not willing to go ahead with treatment, and the risk of re-rupture and mortality and everything has been explained to them. So that is, ruptured aneurysm is clear cut. In our ruptured aneurysms, the ballpark number is around 5 mm. The studies are there for 4 7, but the problem is the longitudinal availability of studies. The population on which the study has been done is very variable, so deriving one thing is quite tough. So two things that we look at: size less than 5, more than 5, and how smooth or well dome the how irregular or regular shaped the aneurysm is. These two things are useful. And the third is vessel wall imaging, in which we can kind of see if there is enhancement in the vessel wall, there is higher chance that that aneurysm might rupture. So once we have decided to go ahead with the treatment, we have an option of coiling. In coiling, what we do, we put some metallic coils within the aneurysm, and it could be a simple coiling that we directly go in, just coil, or we might have to put a balloon along the neck of the. I will show you the images. The assisted coiling means that we are worried that the coils might come out into the main artery. So as a result, we have to make sure that the coils remain inside either with the stent or with the balloon. Second thing is flow diverters. In flow diverters, it is about reconstructing the main vessel. In coiling, what we are doing, we are trying to occlude the aneurysm, whereas in flow diverters, we are trying to reconstruct the parent vessel itself. So that is the primary difference between coiling and flow diverter. It's not just that there is a device which is being used like that, but the primary goal is to reconstruct the vessel rather than just close the aneurysm. So with FD, we are treating the parent artery again. Third part is intrasaccular devices. In the intrasaccular device, it's not just a coil but an entire device that we fit into the aneurysm, and that closes the aneurysm, and there is a lesser risk that it will come out of the aneurysm. The benefit of intrasaccular devices, it some of them are very easy to put, and also we are not putting anything in the main vessel. So in patients who are having ruptured aneurysm like with SAH, we don't have to add any antiplatelets. Whereas if we use stent or we use blood diverters, then the patient will need antiplatelets just like any other stent in the body. Like we do cardiac stenting, peripheral stenting, we have to put the patient on antiplatelets. So a patient who's already had a recent rupture, SAH, all and may need, procedures later on. Sometimes with SAH, we have cerebral edema, we have IVH, we have hydrocephalus. So if those need to undergo an EVD, say ventricular drainage, or a decompression is needed. So at that time, if the patient is on antiplatelet, everything becomes significantly difficult. So that is one way. And then there is parent artery occlusion. So sometimes we feel that aneurysm is an artery which we can occlude and still the brain perfusion will not be affected. So that is one other issue. So that is one treatment. In that we occlude the vessel itself. So it's a very good treatment in the way ki if you're taking off the vessel itself, the chances of reoccurrence of the aneurysm are much less. But the problem is that in brain, it is very difficult to find places where you can occlude the vessel, and you have to keep a check whether it will lead to any stroke if we occlude that vessel, which can cause some deficit for the patient. So we have to ask the patient, or sometimes we assess that it's a very small deficit, but still we need to tell the patient that, if we are occluding this, you might have this stroke, this might happen. So you have to take consent regarding those issues as well. So that is parent artery occlusion. Next thing that we have to figure out is we have to, that some people were asking me last time as to how to report the aneurysm in our report. So we have to tell the perpendicular height or the maximum height. Sometimes it's a dome which is much smooth. We can see here quite a smooth dome. So you can give this height, but if you find out that the dome is slightly tilted and there is some area which is going out and over and the straight height is not the maximum height, then you can give this maximum height with an aneurysm angle. Aneurysm angle is between the neck, if you draw a line along the neck, and the most distant point of the dome. So this is the maximum height, but normally we prefer this. We are able to, define this better. This can be a little subjective, so you just take the perpendicular height, you tell the neck, and this is something that you must mention: the height, the neck, and the maximum diameter. This is called the dome. I will show you in the next images. So this is the width, this is the height, and this is the neck. These are three very, very important measurements that you have to give, which helps in understanding whether these are wide neck aneurysms or narrow neck aneurysms. And that is where you need assisted coiling or normal coiling. In a narrow neck aneurysm, you can just go in with a microcatheter and you can coil, and the coils will not prolapse back into the main artery. Whereas if it's a wide neck aneurysm, or the ratio of the dome and the neck is not that good. So basically you want that the neck should be extremely small and the dome width should be bigger, so that you take a big coil and you put it inside this dome, and it will not come out of the neck because the neck is quite small. Whereas if you have this kind of an aneurysm, then if you put a coil which is